Hi everyone, it's Paul. In this clip I want to look at malignancies in effusion specimens that are not glandular, so not adenocarcinoma. Adenocarcinomas make up about 80% of malignancies in effusions, but there are a whole range of other things. We're just going to look at 3 of those, and the first of these is metastatic melanoma. This is a really difficult diagnosis sometimes. That's partly because it's not that common, and secondly, it can sometimes arise with no known primary site, and thirdly, it can often really quite closely mimic reactive mesothelial cells. This is low power on the edge. You can see this is a supercellular specimen, but it's predominantly dispersed, maybe some sort of loose groups there. Even at this power I can see some really large nuclei, I think. So I'm suspecting this is not just a reactive mesothelial presentation of cells. High power, really I can see here binucleate cell that's got a kind of interesting cytoplasm that seems to be slightly pigmented, eccentric plasmacytoid cells, and some quite large nuclei. So there's significant anisokaryosis here. Here's another field, a really large nucleus, and another binucleate cell that again appears to be pigmented. I can't really see lacy borders around these cells. This is just another area of the slide. It's a bit better spread, and you can see it's pretty much dispersed. Some very loose aggregates of cells. Do they have windows? Maybe a little bit in places, but the outstanding thing really is the pigment in these, and it's looking quite black, that pigment there. Again, these cells just don't look right for mesothelial cells. They're all plasmacytoid. There's a variation in sort of pigmentation from that darker pigment to a sort of dusting of it. And notice how some of these cells have these little punched out punctate vacuoles like those. That's a bit of a feature sometimes of melanoma, thought to be due to degeneration of melanosomes in the cytoplasm. This is the PAP, and it is highly cellular, mostly really dispersed. High power, again I can see the pigment, and here it's got that golden brown appearance to it, what you would expect on a PAP stain. And notice the nuclei, so I'm noticing that these are not hypochromatic like reactive mesothelial cells, but are in fact quite coarse and irregularly distributed. The next malignancy that I want to talk about is lymphoma, and this is responsible for about 10% of effusions. It can be a primary effusion due to lymphoma, but usually there's a history of it. The vast majority of these are already known to have lymphoma. Whether you're told that in the clinical notes is something else. So here we've got a very dispersed population of cells, some smaller cells and then larger ones, and you can see them nicely here. So these are looking like very enlarged lymphoid cells. In the background there are small, more mature looking lymphocytes, but most of the cells are large blastic looking cells. And notice how they have quite a irregular outline to the nucleus. There are indents, lots of sort of bum cells like this, and projections on them. They definitely have a little rim of lymphoid looking cytoplasm on them. And mixed through that are some mesothelial cells, just trying to find some. That's possibly a couple over there. This is the PAP, and as usual with lymphomas it's not as useful. But again I can see a dispersed population, so that's reassuring for a lymphoma. The nuclei in high power have quite a lot of nucleoli, which is sort of a variable thing in lymphomas. There's some mesothelial cells there, some more down here. And again, I can see really what looks like almost two populations of cells. These are mesothelial with sort of smaller, more mature lymphocytes there. But these are quite abnormal looking cells, so I would definitely be doing flow cytometry on this to confirm A, that they're lymphoid, and B, that it's a monoclonal population present. The last thing I want to look at is metastatic small cell carcinoma. So these are usually pleural fluids with a metastasis from a lung neuroendocrine tumour, a small cell carcinoma. This again can be a tricky diagnosis sometimes. Often they're quite sparse in my experience and very blood stained, and finding the cells can be tricky. This case is easier because even at low power you can see tight little groups of cells, definitely cohesive, and they appear to have very little cytoplasm. On higher power you can see there's definitely tight moulding of nuclei present here, and notice the little chains of cells within that I'm pointing out. So looking in there you can see nicely some moulding of nuclei around each other, and again that kind of linear arrangement of the cells in a kind of trabecular fashion there. NC ratio is very high, so we just have a sparse amount of cytoplasm. So I would want to check the pap stains, and I'm looking for the fact that there's maybe some cohesion. We can see here there's quite a bit of variability. Notice how hyperchromatic they are. And I'll be looking on high power to see if I can see nucleoli and also stippled chromatin pattern. This area of the smear is looking quite suspicious, so tight groups of nuclei again. They're a lot smaller on the pap stain. I think I can see some moulding of nuclei around each other. I certainly can't see nucleoli. There's a mesothelial cell there. And again, just a small amount of cytoplasm. Here are some nice chains of cells, and here a lovely little kind of vertebral column of nuclei all moulding around each other, and a few smaller ones as well. I can't see nucleoli. I have to say the chromatin pattern's not great, but it's definitely consistent with small cell. So just in summary, non-glandular metastases are a lot less common, but you really need to be alert for anything that looks like it's not mesothelial cells, because that's going to be a metastasis usually. And use of ancillary tests is really essential in this area. So in all of those examples I showed you, we would use immunohistochemistry, or in case of lymphoma, flow cytometry, to confirm the diagnosis.